Great. Hello, everyone. I'm going to get started with some of our housekeeping items as folks are jumping on to today's webinar. So good afternoon, and thank you for joining us. My name is Brittany Lee, and I am a policy associate at the New Jersey Healthcare Quality Institute. For those of you who aren't familiar with the Quality Institute, we are a multi-stakeholder membership organization that convenes healthcare leaders in New Jersey around the common goal of improving the safety, quality, and affordability of healthcare for everyone. A few housekeeping items. Please know that this webinar is being recorded and a copy will be posted to our website, www.njhcqi.org, later today. A follow-up email will be sent with the link to the recording as well as a link to our NJ-RHAP resources after this webinar is completed. All phone lines will be muted for the duration of this program to limit any background noise, but we will be answering questions at the end of the program, so please feel free to put your questions in the chat box as you think of them. If we don't get to your questions during the Q&A, we'll do our best to follow up with you after the presentation to get you as many answers and resources as possible. Please be advised that it is not the intent of this program or its speakers to provide clinical or legal advice. Now, before we dive into today's content, I want to toss it over to Dr. Stavros Christodias from the New Jersey Doctor-Patient Alliance, a valued member of the Quality Institute who has partnered with us on today's webinar.
Hi, thank you so much. I'm just here to kind of give a quick plug for the DPA, the NJ-DPA. We are essentially an independent provider, independent physician advocacy group, also paired with patients. We do try to stick very much to issues that are unique to the independent practices. We do a lot of advocacy and we're very multifaceted. Everything from trying to help practices, navigate which health insurance to buy for your employees, or which payroll company to use, to we're actually now doing our second amicus brief for the New Jersey State Court, Supreme Court, where we did one earlier that made it that kept the standard for being able to be sued. You needed to have a certificate of merit. They attempted to do away with that. We managed to stop that with the Supreme Court. And right now we're working on one that actually prevents doctors who are sued if the care takes part. It's a case where, for instance, a patient was taken care of in Bergen County. The patient moved to Camden County and now wants to sue that physician from Bergen County in Camden County. Traditionally, the lawsuit would take place in that town where the care was rendered. They're trying to change that rule. We're trying to make sure that if the care was rendered here, the court should be here. It's quite onerous to have doctors and physicians traveling 3.5 hours each way across the state to answer to a lawsuit which may or may not have merit. So again, we're here to advocate for physicians. We're here to answer and help people every which way we can. Right now, we're working very hard in frenzied and crisis mode about President Trump possibly issuing an executive order tomorrow on surprise medical billing and making sure that it's not a unilateral win for the insurers, in which case that even the guys who are in their network would feel that, because all of your reimbursements would probably be halved at the next re-upping of your contract. And we're here just essentially to be a resource, to kind of help each other through experience and through advocacy and through relationships with legislators and or lobbyists, to kind of advocate for the unique things that independent physicians feel. Through COVID, we were here trying to help everybody. Thank you. This is just a very quick summary of things that we do. During COVID, we were doing everything from making sure that physicians were protected with whistleblower laws whenever they wore masks in the beginning of the pandemic, and the hospitals were forcing them to take them off. And then 2 weeks later, we're telling everybody you're not allowed in without a mask. We were there protecting those doctors, writing letters writing to our legislators who would reach out to the hospital saying, knock that off. Everything through, I think we distributed something like 6,000 bottles of hand sanitizer and like 10,000 KN95 masks, and on top of that, another 10,000 regular masks. So we're here to help out, and we're a little bit different than the House of Medicine because that's a little bit more traditional, and I think they focus more on both the employed and non-employed and education. We're here to kind of say, look, it's a small business. Being in practice is a small business. We're here to make sure that we can help those unique facets of being in a small business that we can. So any questions, please feel free to reach out to me or Kim D'Angelillo, our executive director. We're always around to answer, and we'll make sure I'm very easily reachable through the Healthcare Quality Institute. And again, we're very excited and very appreciative of them to allow us to be a part of that, to the wonder that is the HCQI. And we're very, very, very excited about that. Thank you.
Thank you. Today's webinar is a part of our New Jersey Reproductive Health Access Project, and NJ-RHAP is a statewide initiative run by the New Jersey Healthcare Quality Institute. And the focus of this work is broadly to reduce the barriers to reproductive health care that patients and providers face across New Jersey. The main focus of our work in the past year or so has been educating healthcare providers as well as health system leadership, folks that work at front desk, billing and coding staff, etc., around the things that they can do to meaningfully increase access to the full range of contraceptive options, and doing so in a patient-centered way. Our main deliverable as part of this project thus far has been our NJ-RHAP Provider Access Commitment Toolkit, or NJ-RHAP PACT, which is one toolkit as well as additional resources that help walk through background information on this topic, as well as best practices, resources, and really dispelling some common misconceptions around reproductive health care, access to services, coverage, reimbursement, community engagement, and things of that nature. Again, all with the focus of promoting patient-centered care, with the understanding that when individuals are able to access whatever form of contraception they think is best for them, that they'll be most successful in their health and overall well-being. And with the idea that promoting reproductive justice is really at the center of this work, that we want to ensure that we're promoting access to all services, not utilization of services, and that we're really considering all the different aspects of an individual's life that can impact their reproductive health. So the full toolkit is available at this link, and that link will be repeated at the end of the webinar. But as I mentioned, in addition to the toolkit, we also created 10 additional resources that can be used as checklists, reference guides, worksheets, things of that nature. And one of them that is specifically relevant to today's presentation is our billing and coding guide for contraceptive services. So Dr. Levy will be going through a bunch of different codes and important ICD-10 and C codes and J codes to be aware of. And we have a document that has all that information in one place that you can print out and keep somewhere relevant, or bookmark on your desktop. And we'll be sending a PDF of that one pager when we send out the slides and recording of this webinar as well. So we wanted to make sure folks were aware of that resource. So without further ado, I'm going to toss it over to Dr. Levy, who's our presenter for today's content. Dr. Levy is a consultant on our NJ-RHAP project and a lifelong advocate of advancing the quality of women's health. Dr. Levy served as the Vice President of Policy at ACOG, also served as she directed the expansion of the Advocacy Division to support the Office of Global Women's Health, reducing maternal mortality and building sustainable capabilities in several countries. Her work has improved payment policy for OBGYN, while the division's work has improved quality and safety initiatives for care for women, particularly to reduce maternal mortality. Prior to ACOG, Dr. Levy was in private practice. She served as medical director for Women and Children's Services for the Francinian Health System. She also served 2 terms as the chair of the American Medical Association Resource-Based Relative Value Scale Update Committee, advocating for fair payment for physicians. She has also served as a reviewer and editor for several medical journals and graduated magna cum laude from Princeton University. She obtained her medical degree from the University of California, San Diego, followed by an internship and residency at the Oregon Health Sciences University. Without further ado, we will begin our presentation.
So let me try to share my screen here and get this going. We had it all set. There we go. Okay. So it's really my pleasure to be the coding nerd today and to try to share some things with you. As Brittany shared, please don't sit there and try to write down all these codes. They're all be provided for you as we go along. So let's talk for a minute about why become a coding nerd and why understand all these things about billing and coding. After all, we didn't go to medical school or nursing school to learn how to be coders, but it's really important that we optimize the cash flow in our practices, that we are able to provide seamless care for our patients, and that we can run our practices and our offices in an efficient way so that we have the availability to provide those services for people who might be underserved. So there are lots of little nuances and things that we can do that will improve our cash flow and improve revenue for these services. Our patients face a lot of barriers to contraception, one of which is coverage, and we'll talk about that a little bit. For us in the practices, there are issues with prior authorization, with the hoops that the insurance companies and payers require us to go through, especially with respect to particular products, and we'll talk about that a little bit. For some policies, there are very large patient copays or deductibles, particularly these very low-cost policies now that might become available. They sound good in theory, but when you look at those policies, they have either a $5,000 deductible for the patient, or they cover very little or nothing. There are some payer coverage policies that get in the way. They may pay for a device or contraception, but not for the counseling. They may pay for placement, for example, of a long-acting reversible contraceptive, but they may not pay for the removal of that. And as we talk about reproductive justice, that's a major issue and something I frankly think that we need to discuss with our patients in advance as they are trying to choose different methods of contraception. And then for us in our practices, there's the upfront cost of these expensive devices. So as I'm sure you're all aware, the Affordable Care Act does have some coverage requirements for contraception, and for eligible policies, the ACA requires that at least one form of contraception within each of the 18 FDA identified methods has to be covered without a copayment. So, and there are 18 different categories that FDA has assigned, including separating the different types of IUDs. So under that mandate, though, the payer can still have a tiered system within a particular category. So for example, under oral contraceptives, if your patient does particularly well on one product or one dosage, that may not be the one that's covered without copay in that particular plan. So those are all things that we as providers need to be aware of, because it's easy to think that the ACA requires coverage for everybody without copay or deductible, and that's not entirely true. In New Jersey, the law requires health plans sold in the state to cover the mandated benefits, and among those are prescription contraceptives. That's limited, or it includes, but not limited to, birth control pills, implants, diaphragms, at no cost to the patient. It also requires, which I think is terrific, that the plan has to provide at least 6 months of contraception in one prescription. And for the first prescription, it has to be at least, it may be at least 3 months. So we know that the shorter the prescription, the more likely it is that there's a barrier to refill, and that's how unintended pregnancies happen. So your New Jersey law is actually more comprehensive than the ACA. Patients in New Jersey have different options for coverage. One is employer-sponsored insurance, as we're all aware. There is the individual marketplace for the ACA. New Jersey also has the Medicaid program, Medicaid Plan First. To be eligible for that, individuals have to have be able to document a certain level of income. It is also available in New Jersey for qualified immigrants. Plan First only provides reproductive health care, so it does not provide any other preventive health care services. And finally, Title X is a federal grant program dedicated to providing low-income families and individuals who don't have coverage with family planning and related preventive health services. So Title X does cover preventive health services, whereas the Medicaid Plan First does not. So with all that said, how come people still have barriers? Well, there are the exemptions. state and federal mandates only apply to some kinds of insurance. They don't apply to self-insured plans. So if you're a small business or you're a large corporate entity and you decide to self-insure, you can create your own rules, and they are not subject to the federal mandates. Employers can also exercise a religious exemption or accommodation that allows them to withhold either some or all contraceptive coverage to employees. And then some individuals may not have coverage for the particular method that they want. So as I was talking about a particular, maybe brand name contraceptive that works the best for your particular patient, that may not be on her formulary within her plan, and that may be a problem for her. So that's the background for the sort of the coverage environment as it is today, September of 2020. If the Supreme Court rules against the ACA, these rules may all change, although I suspect that your New Jersey rules will not. So having said all of that, how do we do all of this coding? So the way to think about this is the CPT 5 numbered code codes what was done, and the ICD-10 alphanumeric tells a payer why it was done. And in order to get paid on a claim, the what and the why need to match. And payers have all kinds of software that tosses claims out when there's some disconnect between the what and the why. And that's why you have to really become knowledgeable about what things are paired and matched so that you don't fall into those traps. For the CPT coding, there are various types of office visits. They could be separated into categories: problem-oriented visits, counseling visits, behavioral change intervention type of visits, and preventive medicine, and we'll go over those in a little bit more detail. So a problem-oriented visit, the way to think about this is when you have a chief complaint, when the patient comes in and says, today I have itching, burning, or I have pain with urination, so that's a problem-oriented visit. There is a chief complaint and an ICD-10 code that is a medical problem that you can assign to that visit. And that falls into the category of what we were all used to documenting, where it's the chief complaint, the history of present illness, that structure. There are also preventive medicines visits, and that's where the patient's coming in for their annual well woman visit. What's important to know is that that preventive medicine visit does include all counseling related to both contraception, behavioral changes, smoking cessation. All of those are included within the umbrella of a preventive medicine visit, and they cannot be coded separately. There then is a whole category of office visits called counseling visits. And that's when the patient presents for advice about health promotion, and in our case for contraception, and she doesn't have a chief complaint. She wants to talk about options for contraception, but you are not managing whatever set of medical problems she has at that particular visit. So she may be hypertensive or diabetic, obese, all of those things, but that's not her presenting complaint or her reason for being seen that day. If her reason for being seen is contraceptive counseling, then you would use the counseling codes. And finally, the behavior change intervention codes are really codes about smoking cessation, substance use or abuse counseling, alcohol use disorders. Then we would use the behavior change intervention codes. So they're all numbered, 5 numbered codes. 99201 to 99215 are the evaluation and management services codes, and these are for the problem-oriented visits. So contraceptive counseling may have been a component, but not the main purpose of the visit. It's very important for all of you to know that the rules regarding the E&M services are going to change January 1st of 2021 in terms of the kinds of documentation that are required. So up until January, you still choose a level of E&M service for problems based on history, physical, and medical decision-making. Come January 1st, it will just be time or medical decision making. So it's going to make life a whole lot easier for all of us. Just be aware that that shift is going to happen. If you perform a distinct problem-oriented service at the same time as some other encounter, you need to use a modifier, and we'll talk a little bit more about modifiers in order to describe the service. The service has to be distinct, separately documented, and somebody that is auditing your record would have to be able to see that there was some distinct service that required additional resources on your part to provide in addition to whatever else you did. So for example, if a patient comes in and needs an immunization, and she also has a problem, she has a UTI or some other thing, you may need to do 2 things in one visit, and of course that's efficient and it's good for our patients, so there's a way for us to be able to document that. E&M services, again, are based on the time or the level of medical decision making. Until January 1st, you can only use time to code E&M if greater than 50% is counseling and coordination of care. After January 1st, time can be used to choose any level of service based on the total time of the encounter on the day of service. And that includes time before you see the patient, time after, but the total time that it takes you to manage that patient's care that day would be what you choose. The counseling codes 99401 to 99404 are for counseling and risk factor reduction, and they are coded based on time, and they're in 15-minute increments, 15, 30, 45. So when contraceptive counseling is the only reason that a patient is in to see you that day, then these are the codes that we would use, and you choose your level of service based on the time you spent counseling the patient. This is face-to-face time. That means it is time when the patient is in front of you. It doesn't count time that you looked at records previously or that you're documenting or you call the referring doctor. That time does not count when you are choosing these codes. All of these codes are also called in CPT separate procedure. What a separate procedure means is that it is the only service provided on that day. If you do some other thing, like you do a problem-oriented visit, then you have to use a modifier or you will not get paid. The behavior change intervention codes are the 99401 to 412, and that's for patients who have a behavior that's considered problematic, such as a substance use disorder, and we're not really talking about that today. The preventive medicine visit codes are things we use very, very often. They're based on whether the patient is a new patient or established patient and the age of the patient. They are comprehensive visit codes, and they were actually valued by the RBRVS Update Committee as comprehensive services, which means they encompass all of the age-appropriate counseling that you would tend to do for a patient at that age level. So for adolescents, you're going to be talking about sexuality and contraception. For perimenopausal women, you may be talking about menopause, but all of that counseling is included within these codes. So no other services can be reported on the same day as a preventive medicine service, with the exception, and you'll see this later, of immunizations and some other things. But if it's a cognitive service, I'll say, it cannot be reported separately on the same date as a preventive medicine visit. So services that are not included that can be separately coded would be ancillary studies, immunizations, a pregnancy test, for example. If an ultrasound is indicated and that's performed in your practice, in your office, that can be coded separately. If there is significant additional work associated with an abnormality or pre-existing problem, there is a way to do what we call a carve out and to try to code that separately with a modifier. The problem there is that definition of significant additional work. So a comprehensive preventive visit includes a comprehensive history and physical that's age appropriate. So any amount of history and physical that you're doing beyond that is going to be hard to justify. And similarly, it includes all of the age appropriate counseling. So if it is a problem-oriented visit, in addition to preventive care, it would have to require a substantial amount of cognitive services on your part in order to justify coding additionally. And we can talk about that in some of the cases as we go over them. The CPT codes for procedures, so think about IUD insertion or removal, think about implant insertion, do include a brief and focused history. They include checking the use of medications and allergies. They include a brief discussion about the procedure, its side effects, basically your informed consent and getting questions answered for your patient. They include administration of local anesthesia, performance of the procedure, and then post-operative observation on the day of the procedure. So you would not bill separate E&M services if these are brief, focused, all around just completion of the procedure. So what's a modifier? A modifier is a two-digit code that we use on the end of a CPT code that helps to define additional services or some change in the way the service was provided. So the 25 modifier is the one we've been talking about, and it defines significant and separately identifiable in your documentation E&M service on the same day as a procedure or other service. So we would use the 25 modifier if there was a significant and separately identifiable service. It is applied to the E&M service, not to the procedure or other service. 51 modifier tells us that multiple things were done on the same day. And when codes are valued, they are valued to include that brief history, the obtaining the informed consent, the medication use, allergies, all of those things. Well, when you do two procedures on the same day, you don't do all of those things twice. So payers will discount the second procedure by that overlap in work that is being done only once for the two procedures. The 51 modifier should be applied to the lower valued procedure because the first procedure will be paid at 100%, and the procedure on which the 51 is appended will generally be paid at about half. So it's important to know how many RVUs are assigned to the particular procedure you're doing so that you know which one to put the 51 modifier on. The 22 modifier is for increased procedural services. We use that when the service is particularly difficult, involved, it takes a great deal more time. It's not a typical situation. And it requires justification, it requires documentation, and it requires a paper claim. And we'll talk a little bit about the downsides to some of these things, but if you have to provide documentation and a paper claim, then the payer all of a sudden can take as long as they want to pay you, and it goes off on the corner of somebody's desk because it's trouble. It's not an easy computerized, we're just going to pay this claim. It is somebody's got to actually think about it. And when somebody has to think about it, it delays it. And it may delay it for a long time. So you have to decide if rapid payment and timely payment is more important than an additional $10 or whatever you might get for the 22 modifier. 53 modifiers for discontinued services. And we use this when the service is discontinued for some reason, either patient intolerance or some medical difficulty. And we'll talk a little bit about in a case to talk about why that might happen. But let's say we try to put an IUD in and we're not able to. Either the patient can't tolerate the procedure or she's got a cervical stenosis and we're unable to get the IUD in. We might use the 53 modifier with the insertion code to document that we indeed did the work, but were unable to complete the procedure. So how do we go about contraceptive procedure coding? So we'll code for counseling as appropriate, and that's when significant time is spent. And remember, the counseling codes, the minimum is 15 minutes. And then we'll additionally code for pregnancy test when that's indicated, for a device if we're using a long-acting reversible contraceptive device. We will also code for the insertion of the device, and then any additional tests or services, such as an ultrasound, that might be needed on the date of the service. And again, please don't write these things down. This will all be provided for you. But IUDs, we have basically 3 codes. We have, or 2 codes really. We have insertion of the IUD and removal of the IUD. If you are inserting a new one and removing an old one, you want to use the removal code as your primary code and the insertion as your secondary code, which is completely counterintuitive to most of us. But it turns out that removal of IUD has higher work RVUs than insertion of an IUD. And if we have time and somebody has a question, we can go through the history of all of that. But for you to know, when you're doing a removal with insertion, with reinsertion, please add the 50 modifier to your insertion code. The contraceptive implant, on the other hand, has a separate code for removal with reinsertion. And so that's the code, the 11983, that you would use if you're taking out and replacing an implant on the same date of service. And then there are what are called J codes, or HCPCS2 codes, which describe the device itself. And there are separate codes for each one of the separate devices. And so you have to be very, very clear when you're pre-authorizing with your payer. Use the J codes so that you and they are all clear about which device you intend to provide for your patient, which one your patient has chosen. Because they might say, for example, we cover IUDs. Well, they may cover one, but not all. And it's very important for you to document that discussion with the authorizing payer, get the name of the person that you talk to, and get the specifics of that prior authorization, including the J code that you presented to them. If you're going to use Depo-Provera, then you have 2 codes to use. One is for the injection itself, and this is 96372, which is a therapeutic, prophylactic, and diagnostic injection or infusion that excludes chemotherapy, and it's not for the highly complex medications. And then the J code for Depo-Provera is a J code for 1 milligram. And so in the units box on that claim form, you must use 150 units if that's the dose that you've given. So it's J1050. Well, now we're in the midst of COVID and we've got lots of telemedicine going on. How do we code for a telemedicine encounter? Interactions for telemedicine are distinguished by a whole bunch of different things. One is the format and timing of the virtual visit. One is the purpose, whether it's for chronic monitoring or ongoing monitoring of a condition like COVID. If you were managing a patient at home, you might have remote monitoring as the code that you would use. But encounters are also distinguished by who initiates the encounter. Is it the physician office trying to oversee something going on with the patient, or did the patient reach out to us for the encounter? Whether it's an audio-visual or a phone-only encounter, or whether the discussion is synchronous or asynchronous. Synchronous means we're talking to each other in real time. Asynchronous means we're doing email, we're doing text messaging, but it's not real time necessarily. As a response to COVID, I'm sure most of you know that CMS has lifted most of the restrictions on coding for telemedicine, and they are paying at the same rate as an in-person visit. They have extended that for a few more months, I think till the end of the year, but it's not known what or how the rules are going to change. So I recommend that if it's not CMS as the payer, that you know what your payers' policies are and how much they're paying for telemedicine visits. There are codes for these asynchronous visits, and it's really clear that many of us spend a lot of time, certainly our clinic and office staff spend a lot of time with patients on the phone or via secure portal or email. There are services that the CPT editorial panel and the RUC have clearly defined as work that our practices are performing. Often payers are not paying for those services, but we are hopeful that as care coordination and as this public health emergency plays out, that coverage for these additional services will be forthcoming. For synchronous telemedicine services, real-time, audio-visual, CMS is covering that 100%. They have also decided to cover telephone visits, not without the video portion, at 100%. 95 is the modifier that you apply to the typical E&M code, so the 99201 to 99215, or to your counseling codes. If you're doing those services via telemedicine, you use the 95 modifier that distinguishes that as a non-face-to-face visit. Well, okay, so we've spent some time on on CPT. What about ICD-10? ICD-10 has a general category for contraceptive management. It's Z30. If you submit Z30 with your claim, it's not going to be covered because it's not specific enough. So ICD-10 codes go out to multiple digits. Z30.0 is Encounter for General Counseling and Advice on Contraception. Z32.02, Pregnancy Test Exam Negative. And you'll use that one a lot, and I recommend that you keep it. You know, in my practice, what we did was we had a laminated sheet that had all of the relevant codes out to the level of specificity that we needed to have. So, for example, Z30.017 is Encounter for the initial prescription of implantable contraceptive. So it's reported for the prescription and the counseling advice and insertion of the implant, even when the insertion is performed at a separate encounter. So you might end up with two different visits, and you would use that same code the day of the insertion and the day of the counseling. If the patient comes back and says, I can't feel it anymore, I need you to check it, then it's Z30.46, surveillance of the implantable subdermal contraceptive. If you're going to reinsert or remove it, you would also use this code. IUDs have lots and lots of codes for us. And again, I'm not going to walk through all of these. It's boring to just read them to you. But understand that there are initial prescriptions, there are insertions, there's routine checking. So if a patient comes in and says, I can't feel the string, or you ask a patient to come back for a follow-up check, you would use the follow-up, the routine check code. If it's removal, it's 0.432. Removal and reinsertion is a different ICD-10 code. So for example, if you use the wrong ICD-10 code, if you're going to use Z30.432 for removal, but you actually did removal and reinsertion, the payer's not going to, it's going to be a mismatch, and they won't cover it. They'll kick it back out and reject it. So it's really important that you understand the granularity of these codes and you use the appropriate one for the appropriate reason. And again, there's initial prescription of birth control pills, contraceptive pills, encounters for emergency contraception, injectable contraception, and then the J code for the units of Depo-Provera. There's a code for the ring, the patch. You can see the slide. just understand this level of granularity is necessary to get paid efficiently for the services that you provide. So that's an overview of CPT and ICD-10. I think the challenging pieces are the pieces to understand the granularity of ICD-10 and to understand how and when to use modifiers for the CPT codes. I mean, anybody can read the codes in the code book, but it's a question of when to use the contraceptive counseling codes, when to use the preventive medicine codes, when to use a problem-oriented visit code, and then when modifiers are appropriate. So we'll spend a little time and go through these case studies so that maybe we can illustrate some of these points and make it a little bit more clear. So let's start with the first one. JL is a 44-year-old hypertensive patient seen for evaluation and management of abnormal uterine bleeding. So evaluation and management, this is a problem-oriented visit, a 99201 to 992015. A relevant history and physical examination are performed and a differential diagnosis is established. Labs and imaging are ordered and options for management are reviewed. The patient discloses that they are recently divorced and soon may be in a new sexual relationship and didn't think they could become pregnant at 44. So you spend an additional 15 minutes talking about contraceptive options, STI prevention, and overall management of this new situation for the patient. So how would we go about coding this encounter? So for 2020, for 2021, total time in the encounter may be used. Only if 50% is counseling and coordination of care. So I confused myself and all of you. Up until January 2021, you may only code based on time if more than 50% of the encounter were counseling and coordination of care. Likely with this patient, most of your encounter was on the diagnosis and management of her presenting complaint. And therefore, you're going to choose a level of an E&M service based on your medical decision-making. And that's going to be on the level of history, physical, and medical decision-making that you did. If you spend substantial time in the counseling, it is possible to code separately and try to carve it out. But I will tell you that the likelihood that that will be kicked out and rejected by the payer is very, very high. So if you spent, let's say, 25 minutes with the patient, and 15 minutes of that were counseling and coordination of care on the contraception piece, then you could report a counseling code for that. You could also report the appropriate level of problem-oriented visit because 50% of your time was on counseling and coordination of care. This is going to get far easier come January 1st of 2021, where it's just total time on the date of the encounter, and it doesn't matter what happens during that time, or it's the level of medical decision-making. Either one can be chosen, and you can go back and forth. So if patient A, it's more advantageous to you to code by time, that's fine. And then patient B, you might choose to code by medical decision-making. So we have a short window here where it's still the old rules, but things are going to get a whole lot better, I think. So I'm going to go ahead to next one, and this is about counseling. So KS is a 35-year-old patient with chronic hypertension, diabetes, and obesity. And she comes in requesting birth control pills. She loves her birth control pills, and her friend's done really well on birth control pills. Her medical comorbidities are such that they preclude safe prescription of the combined oral contraceptives that she's been on. And considerable time is spent providing counseling about the options for safe and effective birth control. So how are we going to do this one? Is this a problem-oriented visit? It is not. We are not managing her hypertension, her diabetes, or her obesity at this particular visit, even though they are comorbidities that clearly impact what we're going to be addressing with her. The purpose of her visit is contraception. And for that reason, we can't assign a chief complaint other than that she requested counseling. For that reason, we're going to use the counseling codes, the 99401 to 99404, depending upon the amount of time that we spent with the patient. So 15, 30, 45, 60 minutes. And this is face-to-face time. This is not our total time reviewing records and all those other things. And the diagnosis code for this would be Z30.09, Encounter for Other Contraceptive Counseling. So again, even though she has the medical comorbidities, the purpose of her visit was contraceptive counseling. And for that reason, we are going to go ahead and use the contraceptive counseling or the counseling codes. And in the book, they don't say contraceptive counseling, they say counseling, because this could be for STI prevention, it could be for other things. So let's go on to something a little bit more complicated. So TK is a 37-year-old patient who's been on combined oral contraceptives since the birth of their last child 5 years ago. TK is overweight, she has type 2 diabetes, and has recently been diagnosed with hypertension. Primary care physician took them off oral contraceptives with a referral to you for counseling regarding contraceptive options. Comprehensive counseling is provided, including all non-estrogenic options. 30 minutes is spent counseling and providing tools for shared decision-making. TK decides to proceed with an injection of Depo-Provera during this visit as their chosen method of contraception. So how do we go about doing this injection and the Depo-Provera? And I would say in my practice, probably a pregnancy test, if there's been some increment where she has been off her oral contraceptives because her primary care took her off, that may be something that we definitely want to do. So how do we code for this? Again, this is preventive medicine counseling and or risk factor reduction provided to an individual, separate procedure. So we spent 30 minutes talking with her about all of her options, doing shared decision making, really helping her come to a decision. We can use 81025 for the pregnancy test with a paired ICD-10 code that says the pregnancy test was negative. So remember, if you're going to do the pregnancy test, then you can't just use the counseling code. You need an ICD-10 code that says the result of that pregnancy test. And then we're going to use the code for the injection, therapeutic, prophylactic, or diagnostic injection, and the code for the product, the Depo-Provera, and again, 150 units. And with the 96372 and the J1050, we need an ICD-10 code that's the Encounter for Prescription of Injectable Contraception. Now, why didn't I put modifiers on all those things? Injections, tests, and medications are allowed along with a counseling code, whereas another evaluation and management service would not be. So I don't need to use a modifier. There are some payers that if you're going to do an ultrasound, they may require a modifier. CPT rules don't require that, but you may find with some payers that they want you to use a modifier. It never hurts to ask the question up front. If you're not sure, it's far more efficient to ask your provider rec in advance what that particular payer would like to see than to have a claim rejected and have to resubmit it, because that takes a lot of time. Okay, let's talk about case 4. We've got AS, and she is a 27-year-old established patient, and she's coming in for an annual exam and to discuss birth control options. She's sexually active, does not want to become pregnant. She smokes a pack of cigarettes daily, has a BMI of 28, and is generally sedentary. So during this visit, you obviously are going to talk about lifestyle modification, smoking cessation, healthy diet, and review goals for contraception. You perform an age-appropriate examination, and after discussion, patient decides to try low-dose oral contraceptives. You provide a prescription for 12 months of pills and educate her about follow-up care if there are any issues with the medication. So how are we going to code for this one? We spent a lot of time counseling this patient. So she's an established patient. The correct code is 99395. It's a periodic, comprehensive preventive medicine reevaluation and management of an individual, including an age and gender appropriate history, examination, counseling, anticipatory guidance. So that was our guidance about exercise and diet and all those things, risk factor reduction interventions, and the ordering of laboratory diagnostic procedures, age 18 to 39. So you can see that this really is a comprehensive service. It is all-inclusive, and you would not code separately for the smoking cessation, for the contraceptive counseling, or any of the other age-appropriate screening. Let's say you gave her counseling regarding COVID immunization, or Tdap, or some other immunization that you think she needs. You can bill for the immunization if you provide it, but you cannot bill separately for the counseling. And then your ICD-10 codes would be two. Not only the encounter for the general examination without abnormal findings, so the Z01.419, but also that you prescribed oral contraceptives, the Z30.011. And I'm going to stop for a minute and talk about why adding these additional ICD-10 codes is important. Payers are constantly grading us based on the cost of the care that we provide to our patients. They call them efficiency measures. But efficiency measures, to be reasonably accurate, need to be risk adjusted. And the only way for a payer based on claims data to know how complicated your patient is via ICD-10 coding. So if we only use one ICD-10 code, that might be enough to get paid for this visit. In fact, it probably would be, but it doesn't accurately define the entirety of the visit that happened. And I encourage practices and providers to use as many appropriate ICD-10 codes as necessary to define that encounter, so that when people are using claims to do risk adjustment, that it's clear the totality of what's going on with that patient. And I realize that that's additional work to add these Z codes and the additional codes, but it is important as we are being graded, we are being assessed by the payer community, just like we assess them. Okay, let's practice a little bit with removal and reinsertion. So NG is a 32-year-old patient. She had a 52 milligram, 5-year duration levonorgestrel IUD inserted 5 years ago and desires removal of the IUD and reinsertion of a new one. Minimal counseling is required as the patient had no problems with the IUD over the last few years. After vital signs are documented, the IUD is removed without difficulty and a new 52 milligram 5-year duration levonorgestrel IUD is inserted. So how are we going to code for this? Remember that doing a procedure includes some minimal amount of counseling, getting the minimal history of current medications, allergies, those kinds of things. So in this particular case, we would not code for an E&M service. This is a lady who understands all about her contraceptive methods. She's happy with it, and she just wants to have another 5 years. So we would then code for the removal, the reinsertion with the 51 modifier, and code for the device. The multiple procedure add-on is added to the lesser valued procedure. So IUD insertion is allocated 2.28 RVUs in 2019, and removal has 2.70. So the modifier is applied to the insertion code because it's the lower valued code. And then the ICD-10 code that we would use is for removal and reinsertion. So again, some of this doesn't make logical sense to a lot of us, but these are the rules, and this is the way that we can best code for these services. So let's say that patient is in for a procedure. How are we going to be efficient and help her with contraception at the same time? So GZ is a 27-year-old patient. She presented with heavy bleeding at 9 weeks gestation, and by a limited ultrasound, you found that she had a non-viable pregnancy. Uterine evacuation in the office is recommended after counseling this patient about her options, including, watchful waiting. And she requested placement of a copper IUD during the same encounter. The physician spent a total of 25 minutes counseling the patient about the miscarriage and about contraceptive choices. So when coding by time, 99214 is 25 minutes of face-to-face time. In this particular case, this patient's evaluation and management service was significant and separately identifiable. So she's got two things going on. She's got a miscarriage, and you're going to deal with that whole scenario, but she also has a need and a desire for contraception, separate issue. So we want to make it very clear that we have provided significant problem-oriented evaluation and management services for the management of the miscarriage. That's the 99214 with a 25 modifier that says significant and separately identifiable evaluation and management services at the same day as another procedure. We're going to code separately for the transvaginal ultrasound that we provided. And again, generally ultrasound does not require a modifier, but do check with payers because some do want it. We performed a suction D&C in the office. Code for that is 59812. Incomplete abortion completed surgically, and that has 9.37 total RVUs. We also inserted the IUD. So we are going to append the 51 modifier for the IUD insertion because the total RVUs there is substantially lower. And finally, we're going to code for the copper contraceptive, the J7300, for the device itself. So this is going to be a fairly complex coding scenario. Frequently, I would say offices will miss one of these codes and leave money on the table. So very important to understand that you can be coded and you can bill for all of these things. And then finally, the ICD-10 codes that you need to do this is an O, not a 0, in the obstetrical series of codes. 03.39, spontaneous abortion with other specified complications. And the specified complication is that it was incomplete. And then Z30.430, insertion of the IUD. Let's say the miscarriage was complete and it did not require surgical intervention. Then what we would do is our E&M service with the 25 modifier, the IUD insertion, the IUD, and the ultrasound if we performed it. But obviously we don't have the DNC in addition to that. Also important to understand that there are different time periods for which we have to provide services after certain kinds of procedures. So IUD insertion, most of the things we do in the office have 0-day globals, meaning that we take care of the patient that day, but if she came in 2 days later for a problem, we would code again. For a DNC, for a LEAP, there are longer global periods. And so it's important to understand that if you are seeing a patient back during a global period for a particular service, if you are doing something that's totally different, you also need a modifier for that, because your payer is going to bundle it all into the 10 days or 90 days, even though it may be something completely different. If it is, there is a modifier to justify that, and you would need to use it, and it's a 24 modifier. So what about somebody comes in with the missing IUD strings? So KM is a 22-year-old patient, and she complains about being unable to feel the IUD strings for a device that was placed last year. Well, the correct coding for this will depend on the level of service that you need to provide to manage this patient. So if on examination you're able to tease the strings out of the internal os, then that's likely to be a low-level E&M service, maybe a 99213. And your ICD-10 code will be a Z30.431 routine checking of the IUD. But let's say you're unable to find the strings and you provide a limited ultrasound examination, and that documents appropriate location of the IUD. You would then still code a low-level E&M service plus the limited ultrasound. So, and this 99212-3 means you might choose a 212 or you might choose a 213. There is no 212-3. Just depending upon how much time you spend counseling the patient and the level of history and physical examination that you perform. You don't need the modifier to report an imaging study in conjunction with those services. And here your diagnosis code would be T83.32XA, displacement of IUD in initial encounter. You have to use something to justify that ultrasound. Otherwise, your payer doesn't think anything about your visit. So the T code would be applied to the ultrasound, and you could apply the IUD checking code to your E&M, or you could apply the T code to both. So now we get into sort of the nitty-gritty, the tougher ones. So SP, a 37-year-old patient, comes in requesting IUD placement. She has a history of 3 previous cesarean births. So access to the uterine cavity is challenging due to scarring and the position of her uterus. And after multiple attempts at IUD placement, the procedure is abandoned due to patient discomfort. So a lot of us might just let that go and maybe code an E&M service for that, although she really doesn't have a presenting complaint. The correct way to code for that is to use a modifier 53 added to the CPT code for the procedure. Your record, your documentation, has to document what difficulties you encountered, and you have to add some ICD-10 codes, for example, for the cervical stenosis. So you would code 58300-53, which tells the payer that you did not complete the service. And you would use the appropriate J code because you have used a device even though it's not implanted. If the service was for an aborted removal, then you would use the removal code with 53 modifier. So 58301 with the 53 modifier. And then N88.2, if it's a cervical stenosis, if that's your issue, you would use that as well. Most payers do not discount the service with a 53 modifier. So you would bill your usual and customary amount for the 58300 and submit that to the payer. And most of the time, you will get paid full amount for that. So let's talk about the things that you can do in your practice to try to implement all of these things and help this work for you. The first thing is to create a culture of continuous quality improvement in your accounts receivable department. So we're all used to the continuous quality improvement when it comes to the medicine and the care that we deliver, but we should have best practices in our office for our front office staff, for our accounts receivable staff, for our billing staff, as well as for our medical staff. I would strongly recommend that you designate a champion in the office to do the troubleshooting, to be the person who really knows the ICD-10 codes in and out, and who knows which procedures you perform in the office, and who can troubleshoot issues when there are problems and identify optimal solutions for the particular payer mix that you have, for the particular way that your patient population interacts with your practice. And those things vary quite a lot. So it's important to have that champion around. For the patient case that we did where a patient came in for an evaluation and management service but wanted an IUD that same day, do you have the policies and procedures in place that will allow that to happen? Do you have somebody free in your office who can get on the phone and pre-authorize that with the payer so that you are not out the funds for an IUD that you've now placed into your patient, and then you find out later they're not going to pay for it, or she has a big deductible or something else that you should have known in advance. So having optimal policies and procedures in the office so that when these somewhat unusual circumstances happen, you've got a system in place to optimize your revenue and optimize care for your patient. Most of the payers have provider representatives, and I would strongly recommend that you become close friends with them because they can give you a lot of advice and help before submitting a claim. So as I said about the ultrasounds, some payers want a modifier. It's awfully nice to know that before you submit the claim, before you waste time with a denied claim, trying to figure out why it was denied, calling them up later, resubmitting the claim, all of which delays your revenue for a service you've already provided. And unfortunately, if it's something like an IUD insertion where you have also provided a device, you will be delayed in getting paid for that device because it's on the same claim. So some may be nice and pay you for part of it, but not all of it, but some may just deny the whole thing. I really encourage you to keep a spreadsheet and articulate all of the claims denials and become familiar with the quirks of individual payers that you have. And that way you can try to avoid future problems. You can understand what you're doing that's causing the denials. You can call them in advance. But that's that process of continuous quality improvement. If we don't measure it, if we don't know what's happening, then we can't prevent it from happening the next time. So keeping a spreadsheet, keeping something so that anyone in the office could take a look and see what the issue is. And if you have problems with a particular payer, and now you have documentation that you've got several patients where the same problem has happened, and maybe they're inappropriately denying claims, and you go back and then the second time through they pay it, this is an opportunity then to go back to your provider rep and say, look, these things are happening, this is not appropriate, and engage with them. I also recommend that you use resources. ACOG has a coding ticket system, so ACOG has employed coders who are focused on women's health, and they are focused on contraceptive coding. And if you believe that a payer is inappropriately denying your claim or that something's not right, ACOG will allow you to submit a ticket. You would send to ACOG your documentation and your claim form, and the coders will review it. If they're not sure what to do, they do review it with the coding committee, the experts that the college has on a committee. and we'll get back to you. If ACOG agrees that it was improperly denied, and most of the time we do agree with you, ACOG will provide a letter or support for you. So there's nothing quite as powerful as something on ACOG letterhead that goes to the payer and says, look, this is our coding advice and this is how we have told our members to code for these particular things. So all of those are going to be helpful things for you as you go forward. To optimize cash flow, you want to verify coverage every single time the patient comes in the door. Even if she came in this week and then next week it's the first of the month, if she hasn't paid for her policy, she may be dropped. So verify coverage every time a patient comes in. Be specific in asking which devices are covered. So as I said, they may cover one form of contraception in a particular class, but not all. Collect deductibles and copays prior to the visit. In my practice, we took Visa, MasterCard, preferred not to take checks, but we did, and cash. But the patient is most motivated to pay you for the services that you are providing. And remember, she's buying a service from you before you have provided the service. Once that IUD is in, or once she has had the service, she's less motivated. For the expensive devices, consider bulk purchasing if you can, if you have the resources to provide, to purchase 5 or 10 at a time. You'll get some discount and that provides a bit of cash flow for you. And then definitely keep up to date on the cost and your payment for LARC devices, because when a price increase occurs, immediately, if you will send an invoice to all payers, they should and are required to update their payment to you. So as soon as you can document an invoice with a higher price than you're getting paid, send that immediately to your payers. As I said, keep a spreadsheet of payers, contacts, the specific people. We used to submit claims every day to avoid denials due to late submission. You can choose to do them daily or weekly, but don't get behind in sending in your claims. Again, ensure that your ICD-10 codes are accurately and completely justifying the procedures and the services that you perform. So every time you're adding another CPT code, be sure you have the right ICD-10 code to append to that. Verify the coverage at every visit and track prior authorization requirements. In theory, with the ACA for contraception, you should not need prior authorization. That said, I recommend getting prior authorization for particularly expensive devices and going forward with that. Remember to code for the highest level of specificity. Payers will reject a claim if it says unspecified. And keep that laminated list at your front desk or wherever your coder is to make it easy for you to do the correct coding. Lots and lots of resources for you. And again, these will all be provided for you, but particularly I would say ACOG's coders are a huge resource for you.
Hello?
And with that, I will take any questions.
Thank you so much, Barbara. That was a lot of really helpful information. I think that's important for folks on the line to think about the intricacies of contraceptive care, billing and coding specifically, because we hear that a lot of the reasons that reproductive health providers may not be able or willing to provide the full range of contraceptive options is because they're concerned about denied claims. So having all this information up front and being able to address some of the myths or misconceptions about these services is really useful. So we have a couple of questions that we have for Barbara in the 10 or so minutes that we have left, but I wanted to remind folks that if any questions come up, to please put them in the chat box and we'll do our best to get to them. Barbara, the first question that we have for you is, how can, in offices where providers are doing most of the billing and coding, how can practice management and other support staff support those providers, or in situations where there's select teams to process that billing and coding, how can providers support them to make sure that they're doing these best practices and effectively coding for services?
So I think it's helpful to have a team meeting. I mean, we all do team-based care, and I love team-based care, and it's really about having that some contraceptive champion in your practice. And that could be a provider, it could be a coder, it could be anyone, but it's all about communication. It's making sure that I, as the provider, tell my coder when I've done something unusual or something hasn't happened the way it normally does. And it's also about keeping up to date. So you need to have new books every year, unfortunately, for both CPT and ICD-10 so that you're using current codes. But it really is having that team meeting. Maybe it only needs to be once a year when the new codes come out, but sometimes it may have to be more often than that if payer policies change. If you're getting a lot of denials, then I would say sit down together and figure that out. Okay, look at them as a team and try to figure out why those denials are happening. Are we not coding to the level of specificity? Are we trying to get paid for a problem-oriented visit and a preventive visit at the same service? I mean, in theory, you could do that, but when you understand how much of a history and physical is required for the preventive service, it's awfully hard to say that something was a significant and separate service for that.
That's great, thank you. Another question that we had was, we mentioned one of the case studies, what happens when an insertion of an IUD, for example, is particularly difficult or not able to occur for a variety of reasons, maybe related to the patient. But what would the case be if a device is maybe damaged before insertion begins? So maybe a provider notices when they're taking it from the package that something seems not to be right with it, or it's dropped on the floor or contaminated in some way before insertion. Is there a certain way to address that in billing and coding, or address that with the manufacturer?
So yeah, that should be with the manufacturer. So if you waste a device, and we call that waste, you know, you haven't touched the patient with it, but you contaminated it, fell off the tray, it doesn't look right when you look at it. Most of the manufacturers, in my experience, will allow you a little bit of leeway. They'll replace that device for you. I think in terms of managing your practice, it's always nice to have an extra one around, because sometimes those things do happen. I mean, bad things happen. And the patient will be really disappointed if she came in to get an IUD insertion and something happened and the IUD you open is not usable for some reason. So the manufacturers are awfully good about that, and I would strongly recommend, you know, you certainly shouldn't eat it, but neither should the payer. I mean, if the device is wasted, usually the manufacturer will comp you one.
Yeah, that goes back to your earlier suggestion of having good relationships with those reps, because they're important, not just for getting the devices, but any follow-up questions that you have afterwards.
Well, and I was talking about the provider reps for the payer, but yes, you want to have good relationships with the suppliers for your devices too. Yeah.
Great. So in addition to contraceptive care that's being provided, if someone came in primarily or really solely to talk about contraceptive counseling and receive contraception, but in that visit, either based on a conversation that you had with them or symptoms that they described, during that conversation, it was discovered that they needed treatment or testing for an STD, would that be billed and done within the same visit, or would the patient need to return then for the contraceptive initiation after STD treatment was completed?
So no, current recommendations are that we can simultaneously treat an STI and initiate contraception management at the same visit, and that's absolutely what we want to do. Those patients are at risk for unintended pregnancy, and so you want to do both things at the same visit. Whether you elect to code that as an evaluation and management service or a counseling service will really depend on what the bulk of your visit was. If the bulk of your visit was contraceptive counseling, you might use the counseling code. If the bulk of your visit was pelvic pain and STI and looking under the microscope, then you might choose to use an E&M service, a 99213 or 214, and then provide the contraception.
Great, thank you. As we mentioned earlier in the presentation, reproductive justice is something that's really important to consider when providing these services. And one of the concerns around reproductive justice, specifically as it relates to long-acting reversible contraception, is a patient's autonomy to decide if that form of contraception isn't working for them, to have it removed before that time limit. So if they're receiving an IUD that has a five-year duration, but they decide that maybe due to side effects they want it removed ahead of time, we know that that's something that should be done and discussed with the patient. But if they were to decide that maybe they wanted that IUD removed but wanted to try a different IUD, would an insurance likely cover a new device, assuming that both of those IUDs are covered by their insurance, or is there a limit due to that duration period of a certain device?
No, there isn't a limit. And in fact, it's pretty fascinating how little payers know about the history of what happened to this patient 6 months ago. I mean, it's not one of the things they track. They track a lot about that, the CPT and ICD-10 matching. They track a lot about utilization, like how much does it cost for me to take care of that patient over time. But they don't necessarily know what somebody else or I did 6 months ago specifically. So I think the thing about reproductive justice that bothers me the most is that insertion is covered and removal isn't covered without a copay. And to me, that's anathema, and it's not as we would want it to be, but it's important for our patients to know that they will owe a copay or deductible or both for removal of a device, not for insertion of the device if their payer fits within those categories that we talked about earlier. So, I mean, that's something that the reproductive justice community has been negotiating and talking with people about. We've not been successful yet at trying to ensure that removal is also covered.
Yeah, that's definitely, it's important to know from an advocacy standpoint and also for patient education, because depending on a situation, things like that can be prohibitive. So that's a great point.
And as I said earlier, I think it's really important to talk to women up front before inserting a LARC, to let them know that there will be a copay and or deductible if she chooses to have it removed. And I wouldn't say that in a way to try to discourage her, but just so she's informed, because that financial barrier can be significant for some people, and it might make her in shared decision-making choose another option. So I do think it's important for us to disclose that up front.
Yeah, I think especially due to the duration of some of these devices, even if, depending on, you know, if they're insured through Medicaid and maybe they're not, or another insurer and they're not having a copay for the removal, but in that time period, their insurance could change, and their coverage for those services could change. You know, it's very common for over a 5-year period, someone to have a different employer insurance, or for their employer to be using a different carrier. So even if at the time it's not a factor for them, it's very likely that it could be down the line.
Could be, yeah.
Well, those are all the questions that we had. Barbara, we want to thank you so much for all of this information. Like we mentioned before, the recording and the slides for this presentation will be available on our website and will be emailed to our participants later today or later this week, along with that one-page billing and coding guide. Like Barbara mentioned, there's a lot of information there, and there's no need to memorize a lot of it. If you can have it, print it out, laminate it in front of your computer screen or bookmark, you can really start to memorize things slowly and just be able to reference back to them, so that as few errors are made as possible, which is really the goal in a lot of this work, is to streamline things and reduce errors so that more time can be focused on patients. So again, thank you so much for giving this presentation, Barbara, and thank you to the Jersey Doctor Patient Alliance for partnering with us, and for all of you for participating today. We hope you have a great rest of your day. Thank you, everyone.